Welcome to a discussion of pathology of the shoulder girdle. So as you've noticed at clinicals, and as you can see from this slide, shoulder exams are very prevalent. In fact, in 2001, about 14.5 million people went to the doctor's office for a shoulder problem. 3 million of those were for shoulder and upper arm sprains and strains. And we know that shoulder injuries can be caused by sports activities, but really it's the overhead motion from activities like swimming, tennis, baseball pitching, weightlifting that's causing these types of injuries. People who are not athletic and just completing everyday tasks like cleaning, hanging curtains, gardening can also have shoulder injuries. And again, it's often due to excessive overhead arm motions. So the purpose of this lecture is to identify some of the most common shoulder injuries that you'll see at clinicals and that I'd like you to be familiar with before the exam. The first pathology that we'll discuss is an AC joint separation. And remember, AC joint refers to acromial clavicular. So an AC joint separation refers to trauma to the upper shoulder region resulting in a partial or complete tear of the acromioclavicular or coracoclavicular ligament, or sometimes both. AC joint injuries represent nearly half of all athletic shoulder injuries, often resulting from a fall onto the tip of the shoulder with the arm in adduction. Currently, there are 6 classifications of AC joint separation, and they range all the way from a sprain to a complete separation of the distal clavicle from the acromion. And remember, that's a result of a ligament tear. The imaging routine includes bilateral shoulder x-rays with and without weights. And let me show you an example here next. So notice this x-ray, we've included both shoulders on one image, and the benefit of this is that you can easily compare side by side. So to achieve this, we just increase our SID to 72 inches. And again, that decreases magnification and lets us include both joints on one image. So what the physicians are looking for here is they are trying to evaluate any separation between the clavicle and the acromion. And you can see on the right here, there's quite a bit of separation compared with the left or the uninjured side. Using weights actually puts pressure on the joint in question, and that helps the physicians evaluate if any separation is present. Sometimes the separation can be very subtle, so using a weight will really help, again, put pressure on that joint to help the physicians visualize any potential separation. So we have the patient hold weights in their hands or put the weights around their wrists, again, to really put pressure on that joint. This is an elective exam at clinicals as well, so we don't see them very often, but every once in a while. Next, the Bankart lesion. So the Bankart lesion is an injury of the anterior inferior aspect of the glenoid labrum. Okay, well, what is a labrum? Well, a labrum refers to a ring of cartilage around the shoulder joint that aids in stability of that joint. Because remember, the shoulder joint is very mobile, but as a result, not very stable. So the Bankart lesion is often caused by anterior dislocation of the humeral head, and repeated dislocations can actually result in a small avulsion fracture of the anterior inferior region of the glenoid. So let me show you an example. So here is a patient on the left that has a dislocated proximal humerus, and you can see on the image on the right, this patient has a slight avulsion fracture here. So notice this is the anterior inferior part of the glenoid. And please note the labrum won't actually be visualized on x-ray. Remember that cup of cartilage? That really is best visualized in MRI. But again, you can see this small avulsion fracture, and that is a result of this humeral head being dislocated anteriorly. Hill-Sachs here is a different pathology, and we'll discuss that in just a moment. So Bankart lesion is an injury to the anterior inferior shoulder labrum, can result in a small avulsion fracture. But please note, you can have a Bankart lesion without an avulsion fracture. Okay, next, let's talk about that Hill-Sachs defect. The Hill-Sachs defect is a compression fracture of the posterior lateral aspect of the humeral head, and is often associated, again, with anterior dislocation of the humeral head. So you can see right here, that is a compression fracture. In other words, that part of the humeral head is just kind of compressed or smushed in. And that is not normal, right? This part should be nice and full on a healthy humeral head. Let's go back a second and look at that previous slide. Notice this patient here on the right. They have a Hill-Sachs and a Bankart. And again, that can happen with anterior dislocation. So imagine the patient falls, they dislocate that shoulder, causing a Bankart lesion, but they also land on that humeral head, causing a Hill-Sachs fracture. All right, so please be able to differentiate between Bankart lesion, which is the glenoid, and the Hill-Sachs defect, which is the humeral head. Next, idiopathic chronic adhesive capsulitis. This is quite a mouthful, so in layman's terms, we call this a frozen shoulder. And it is a disability of the shoulder joint caused by chronic inflammation in and around the joint. And it's characterized by pain and limited range of motion. The term idiopathic actually means of unknown cause or origin. And patients with frozen shoulder often have physical therapy to help with the symptoms and improve their range of motion. And you can see here in the picture all this irritation here in and around the joint, and that's causing limited range of motion and pain in a patient with idiopathic chronic adhesive capsulitis. So please be familiar with this term and also know the layman's term, frozen shoulder. Next, we have impingement syndrome. So impingement refers to the act of rubbing against something. Okay, so shoulder impingement occurs when the acromion rubs against or impinges on your rotator cuff. And we'll talk about rotator cuff here in just a minute. That rubbing or impinging causes pain and irritation. Now, you don't need to write this down, but just for your information, according to the Cleveland Clinic, when the muscles around the shoulder are irritated or injured, they swell in much the same way your ankle does when it's sprained, for example. However, because the muscles are surrounded by bone, swelling can cause other events to occur as well. Swelling reduces the amount of space around the muscles, and that leads to rubbing against the acromion. Like a vicious cycle, the rubbing of the tendons results in swelling, which further narrows the space below the acromion. In some cases, bone spurs on the acromion can contribute to impingement by causing the space where the muscles sit to be even more narrowed. So again, in impingement syndrome, we often see bone spurs on the coracoacromial arch impinging or rubbing against the muscles there. Okay, typically patients will feel this impingement when they try to abduct their arm. And radiographically, we'll see bone spurs on the end of the acromion. And I actually have an example here that I'll show you in a minute. The best projection to visualize impingement is the NEAR method. And the NEAR method, remember, is a PAY with a caudal tube angle. And usually the tube angle is 15 to 20 degrees caudal. So the NEAR method is different than your traditional Y because of the caudal tube angle. Okay, but please know that if you wanted to visualize impingement, you could do the NEAR method. Okay, so here's an example of a normal shoulder. Just to orientate you, of course, this is the humeral head. Here's the coracoid. Here's the clavicle. And here's your acromion. Now, normally muscles and ligaments and tendons pass through this region. Okay, so notice this patient has a bone spur. This bone spur, of course, then is going to pinch and impinge on the muscles, tendons, and ligaments that pass through this area. And that's what's causing the pain and the limited range of motion. And bone spurs can be caused from such things as arthritis or injury. Next, let's talk about osteoporosis. And you may already be familiar with this pathology, but we'll just review it here again. Osteoporosis is a loss of bone density, usually due to a lifelong lack of calcium. As a result of the loss of bone density, the bones are more radiolucent and have a thinner cortex. Remember, cortex is the outside of the bone. A decrease in exposure techniques is appropriate with osteoporotic patients. Osteoporosis makes bones thinner and more susceptible to fractures. Osteoporosis occurs in postmenopausal women and elderly men most often. And in fact, most fractures sustained by women over the age of 50 are related to osteoporosis. And you can see an example of that here. So pretty significant osteoporosis in this proximal humerus. And again, there is a loss of density in that bone because the bone didn't have enough calcium. As a result, a very light injury or trauma to this area can cause a pathological fracture, which is what you see here. Remember, a pathological fracture occurs when that part of bone is diseased or unhealthy and more susceptible to fracture. And you can see an example here. This is what normal bone should look like. Remember, a bone with osteoporosis is not going to be as stable and as dense. So osteoporosis is important for us because, number one, we can use less technique. We don't need as much technique to penetrate through bones that have osteoporosis. And again, it can lead to fractures, particularly in our older men and women. Next, let's talk about the rotator cuff. And I don't need you to know too much about the rotator cuff. I'll try to hit some highlights here. The rotator cuff is a group of muscles and tendons that hold the shoulder joint in place and allow for movement of your arm and your shoulder. There are 4 different muscles that make up the rotator cuff, and I've listed them here: the teres minor, the supraspinatus, the infraspinatus, and the subscapularis. So when we talk about rotator cuff pathology, that is referring to an acute or chronic traumatic injury to one or more of those rotator cuff muscles. Rotator cuff injuries limit the range of motion of the shoulder, which makes sense. The most common injury of the rotator cuff is actually impingement of the supraspinatus tendon as it passes beneath the acromion. And remember, we talked about impingement a couple slides ago. That impingement, remember, can be caused by the subacromial bone spur, or a bone spur coming off the bottom of the acromion. Repeated irritation from the bone spur can lead to a partial or complete tear of the supraspinatus tendon. And you can imagine that causes a lot of pain and limited range of motion for a patient. MRI is actually the modality of choice to visualize the soft tissue structures of the shoulder, such as the 4 rotator cuff muscles and their associated tendons. So please know that we won't see rotator cuff on an X-ray. Those patients really will be referred to MRI for further evaluation. So here is a diagram depicting the 4 rotator cuff muscles and their location. So just quickly, the supraspinatus, you can see this is a posterior view of the scapula. And this kind of makes sense. Supraspinatus, it is above the spine of the scapula. Infraspinatus, again below the spine of the scapula. Teres minor, located here, and again this is posterior on the scapula. And last, the subscapularis muscle. This is anterior on the scapula, and it kind of makes sense because there is a subscapular fossa there. So the muscle sits in that fossa. So again, please just know that the rotator cuff is made up of 4 different muscles with associated tendons and ligaments, and impingement of that acromion with a bone spur can really irritate or injure some of these muscles. Okay, dislocated shoulder. You will see this a lot. This is a pretty common injury. What is a dislocated shoulder? Well, it is the traumatic removal of the humeral head from the glenoid cavity. And of shoulder dislocations, 95% of them are anterior. In other words, the humeral head is projected anterior to the glenoid cavity. And remember, our Y projection is really going to demonstrate those dislocations very nicely. So let's take a look here. Here you can see the humeral head is not where it's supposed to be. Okay, so you take your AP, in this case it looks like a Gracie. In any case, you can tell something's a little bit off here, right? Then you take your Y projection, because we do a Y with every shoulder series. And sure enough, you can see here is the glenoid right here. Well, the humeral head is supposed to articulate with that glenoid. I can see here, instead, it is dislocated out of that joint space. And this is why the Y is so helpful. We can see it's actually anterior rather than posterior. That's really important when the physician's trying to put that shoulder joint back together. They need to know which way to manipulate that arm. So oftentimes when we have dislocated shoulders, we will take the initial images, they will go back to the emergency room or wherever they came from. The doctor will reduce or replace that humerus back to articulating with the glenoid, and then we will do what's called post-reduction films. So it's films after the shoulder joint has been put back together, just to demonstrate that it in fact is in the correct position. Wonderful. Okay, let's review just a couple things here before we conclude. Remember bursitis. Remember that is inflammation of the bursa, or the fluid-filled sacs enclosing joints. The shoulder is actually the most common place to develop bursitis, but we also saw it in the elbow in the last unit. Symptoms include pain and limited range of motion. Okay, and overuse, again, can lead to bursitis. Remember osteoarthritis. This is a non-inflammatory form of arthritis. Remember rheumatoid arthritis? That was inflammatory. This is non-inflammatory. Leads to a deterioration of the joint space, and it's really thought of as a part of the normal aging process. And then last, tendinitis. Remember that is simply inflammation of a tendon. Usually you see tendinitis resulting from a sprain. Okay, thank you for listening, and if you have any questions about shoulder girdle pathology, please let me know.